here, and this one stops, and this one keeps going. And I get kind of a hard end feel with this one. And it's because the hip can't go in and recenter. So lay on your back. What Jordan did was, he took the hip from greater trochanter, and he's finding it should stay kind of relatively in its position. It should just kind of wiggle in place. And he's finding that when if I have this fixed in this thing, what happens is this gets stuck and this swings up like this into an abnormal axis. So I get this elevation of it. I don't get the spin in place like this is what's missing. So that's what he's doing with the log roll test, is he's feeling this to feel like, okay, trochanter stays centered, it's not swinging up and down because it's pivoting on an abnormal axis because it's lost its posterior glide is the model. So let's get you, toss me a pillow, and let's get you laying on your left side. Man. I'll test here. Sometimes he looked at this in the wiggle. So you can take it in the trochanter. As soon as I do this and grab it, it should have a bit of a wiggle. You should be able to kind of do this. If it's kind of stuck anterior here, it just feels kind of stiff. It doesn't have this loose wiggle. So one of the last things I'll do is I'll test it. If I got to this point, I'm probably going to manipulate it anyway. The wiggle's not going to change my mind. But I like to feel it, feel like, okay, it matches. Like he's got a nice joint play here, but it's not. But for demonstration purposes, it's not going to stop me.
That's his right.
You're on the wrong side.
I mean, his left hip is limited, that correct?
I was just demoing it. It wasn't really limited. I was just kind of showing what it looked like. Sorry about that.
Okay.
Yeah, it was fine. So he's here. So with this technique, you're seeing people kind of coming down maybe like this. And it's just a matter of vector. It would be anterior, anterior, inferior would do it. So how I'll do it is I'm coming in here, and it's probably more what you see is like this, where I have a bit more of an anterior vector than a down vector. I wouldn't come this way per se. I would come this way. I was initially taught it was this. It was a glancing blow, which is a bit more thing. But the problem is I missed this the wrong way. What does that look like? You know, so for, yeah, exactly. So, you know, when, you know, Gail came in one time, I was doing teaching with her or something, and it's like, oh, she changed it a bit. And it's like, okay, yeah, it's much better, I like that. But I found that this is just effective. So I'll look at a cupping technique, but my vector is kind of here, so I still get that glancing blow, but this one, if I miss it, it literally sounds like somebody's just bitch slapping you. I mean, if I do it, he's like, what the hell are you doing? Because he didn't set it up well or talk about it enough, and he lays it off there, and it's a crappy technique. So all of a sudden, it's like, yeah, it's also here. And he's gonna do it 3 times just to get a sense of it. You also kind of take the leg, and you can change the angle and say, okay, which angle may get it more? And come here and try it that way.
Are you sitting behind GT?
Yes, I'm behind it, my thumb is my target, so the thumb sits right behind it. Like here's me pinching anterior and posterior, like what we've done this weekend. I rest my thumb behind it, and I cup it. And I'll demo it to him on some other part of your body. It's like, okay, yeah, it's like, you know, before I set this up, it's like, what I'm gonna do is I'm gonna come to the back of the hip, put my hand here, and I'm gonna come in, I'm gonna hit it like this, and I'll show him the spin thing. I'll keep showing them this. So they have a mental image of what I'm going after and why I'm doing it. So it's not like something that you don't know what I'm doing or why I'm doing it. I let them feel it if I need to here. If I know them, sometimes I don't need to even tell them hop up on the bed. They just come down from the gym, hop up on the bed and say, Dave, hit my hip. I'm like, fine. And I do it, and then they're back off on their run. So there's some people who are just that easy. Not everyone. I think the motor retraining is what keeps it happening. You have to kind of figure out, how do I get that hip to center? What's my best way? Is it a pelvic floor strategy? Is it hip strengthening? Is it foot? Or is it a blend of all of them? And sometimes it's let me do it all. Let me get them solid. And I'll do all of it with them. So that's one technique. Another one would be traction. Good, lay on your back. I don't find this to be as effective for me. I know somebody else likes this. I want a bit more than foot up here. I don't know that I like it. I think if the hip and the labrum is unstable, sometimes what you get is this large gurglunk feeling, because you feel like you're about to disarticulate the hip, and it pops back in. And they tend to like it a lot because it's a ton of neurophys. But for me, it makes me like, oh God, thank God I didn't dislocate the hip, because the hip shouldn't do that. The hip should be vacuum sealed up into the joint. You should not feel it ride in and out when you do this technique. Now, if we're mobilizing into the lumbar spine, oftentimes they'll internally rotate the hip to lock out the capsules, and now my force goes into the SI joint or lumbar spine. If I'm doing a lumbar traction or SI joint traction technique, I'll keep this a little bit looser. Notice as I set this up, it's my body. I set up here my body and my lats. And see me kind of come back with my hips. I'll go here and I'll go slightly internal rotation and I'll pull in quickly. And see, can I set it? I will do this one first on somebody I do not know, just to see if it gets it. And I'll go through my progressions. Like I'm gonna do 3 things, and here's, then I'll talk about the third one that I've been setting up with them. So I don't go right into it with people. That's the one thing I really want you to take home with. I work into that. I can do that and recheck it. This one tends not to work very well either, but I'll do it, and sometimes I get it. Here, internal rotation. And I'll just kind of pull down, just see if it reset it. So if you want to do something that's less noxious on them. But hip smack works the best for me. Traction, possibly. That one, I haven't really had great deal of success, but sometimes it gets it. But that would be my question. If you ask me what I wanted to do first, I would do the hip smack because it's most effective. If it doesn't work, then I'm going to rethink what I did. Did I miss a capsular pattern? Do I have something else going on? If I do it twice, I may do it like 2 times that way, then recheck it, then do it again. Then I need to look elsewhere. This isn't the technique to do it. So I need to kind of sort through it a bit. You could just have a labral tear issue, and it's inflamed. You'll get a sense of that. But you could have an irritated labrum, and this be one of the drivers of the irritated labrum. You do this one, and it feels better. And it gets better. I've seen that where people have been told, I have a labral tear, you should need surgery and do it, but they aren't quite as bad as they probably looked when they rolled in that physician office that morning. So you clean this up, you take the stress off the hip, and then they get better. You'll see that. You'll see this clean up when they have a medial meniscus or their meniscus is irritated because this isn't moving well, that rotary force is getting pushed into the knee joint. You look at this and find they have this going on, then they can remotor train and get it, and the knee gets better in those cases. So don't be surprised when you're looking at this if it's not a lumbar spine patient or a knee patient, that this may be the driver of one of those other things that are going on. So it's just a nice easy one to screen because now you have a scan exam for the lower extremity, kind of looked at the hip in detail, got the sense of the end feel, how it's moving, know how these joints move in space, and if I have a complete understanding of what it can do and what it can do under motor control, then I can kind of really work out what's my postural education, my movement pattern re-education, and my muscle activation through range of motion control. And kind of really get a sense of the lay of the land. Okay, let's try this one.